Good evening. On behalf of the Ceylon College of Physicians and the Sri Lanka College of Pulmonologists, I welcome you all for this live and expert webinar on pleural infection. I'm Dr. Damit Rodrigo, consultant respiratory physician from District General Hospital, Monreale. So today we have with us an eminent speaker who will be going to talk to us on the topic of management of pleural infections, what is new. He is Professor Najib Rahman from Nuffield Department of Medicine, University of Oxford, United Kingdom, and he is a world-renowned authority on pleural diseases. Professor Rahman is no stranger to the pulmonologist fraternity of this country, but it is my pleasant task today to introduce Professor Rahman to this audience. So Professor Najib Rahman is a professor of respiratory medicine and lead for pleural diseases, director of Oxford Respiratory Trials Unit at Nuffield Department of Medicine at University of Oxford. He was qualified in Oxford and underwent medical SHO rotations at Queen's Medical Centre, Nottingham, and rejoined Oxford as a specialist registrar in 2003. He undertook a DPhil and an MSc in this period and appointed as a senior lecturer and director of the Oxford Respiratory Trials Unit, then consultant and lead for pleural diseases in Oxford in 2011. He was appointed as an associate professor in 2014 and then professor of respiratory medicine in 2018. He is currently involved in many randomized and many observational studies in pleural infections, pneumothoraces, and malignant pleural effusion interventions. He has published over 180 papers with citations more than 6,000. So Professor Rahman will be delivering his lecture today on the topic of management of pleural infections, what is new. So at the end of this lecture, I'm sure Professor Rahman will be happy to take up and answer a few questions raised by our audience today. And if you have any questions, please send us through the Q&A option, which is here in this Zoom platform. So now I invite Professor Rahman to deliver his lecture. Over to you, Professor.
Thank you so much, Damit, and thank you again for the honor of speaking to my friends and colleagues out in Sri Lanka. I do apologize for the change in timing. That was entirely my fault. So I've eaten up into your evening and I'm very sorry for that. Let me just share my screen and then I'll get on with my presentation. And as your colleague suggested, I'd be very happy to take questions at the end with no difficulty. So hopefully you can see my presentation. I'll just make sure that I've got a laser pointer available there. So hopefully you can see the laser pointer, is that right?
Yes, of course.
Thank you so much. Thank you so much. So I've been asked to speak about the management of pleural infection. These are my financial disclosures. The ones of relevance to this particular talk are that Roche and Genentech and Boehringer supplied some of the clinical trials materials for the MIS2 study. What are our objectives from today? I want to review the epidemiology of pleural infection. I want us to try and understand the underlying causes and risk factors for pleural infection. We need to understand the microbiology associated with this disease. I'd like to discuss evidence on predictive scoring in pleural infection, and then finally review the literature on optimal management that includes antibiotics, drainage, surgery, and finally intrapleural treatment. Now, this was Guillaume de Puytren. I'm from Oxford. We adore history in Oxford, which is why I'm showing you a very old picture of somebody who died nearly 200 years ago. Dupuytren, he was famous because he was Napoleon's physician, so he was a famous man. And the reason I'm showing you his picture is that he got a pleural infection, and the pleural infection, in fact, was his last illness. And when he got his pleural infection, he said this: "I would rather die at the hand of God than at the hand of a surgeon." He refused surgical treatment in 1835 and died of his pleural infection. Sir William Osler, another very famous medic, of course, considered the father of modern medicine, and Osler is the man after whom my own unit here in Oxford is named, the Osler Chest Unit, because he trained in Oxford and then went to Johns Hopkins. Very famous man, lots of eponymous syndromes. And in 1919, after the flu pandemic, he also got a pleural infection. And he said this: "Empyema needs the cold steel of a surgeon rather than some fool of a physician, by which I suspect he means people like you and me. And he certainly wanted to go ahead and have surgical intervention. He had surgical intervention, and unfortunately he died after surgical complications. Now, you'll excuse me if I keep waving my hands because the lights in here are on a timer. So for a long time, we haven't really known what the best way to treat this disease, as those two famous men have told us. The problem with pleural infection is that it is very, very common indeed. Now, I've produced figures here for the UK and USA, 1.5 million cases of pneumonia per year, and related pleural effusion occurs in up to 40%. Now, you will all know as pulmonologists and internists that the majority of those pleural effusions are not complicated, don't need drainage, but we do need to sample them. And at least over here in the Western world, that means that we're looking at 500,000 cases of pneumonia associated with a pleural effusion. Of those, it is only the minority, 80,000 or so, that end up with complicated parapneumonic effusion or pleural infection. So that means 15% in total of parapneumonic effusions are complicated or frankly infected. And the problem that we have, at least in this part of the world, is that the incidence is very much increasing. Now, I won't go through the epidemiology in any great detail. These are the three best epidemiological studies. For my money, the Grijalva study is the best study published in Thorax about 10 years ago. Farja was in Washington State. Finley is a pan-Canadian study, and Grijalva was a pan-USA study. All of them show exactly the same thing. Even controlling for other disease incidences and other epidemiological factors, there is a year-on-year increase in the incidence of pleural infection. So this is the figure from the Grijalva study. You can see comparing 1996 on the left to 2008 on the right-hand side, there has been essentially a year-on-year increase in the number of cases of pleural infection and empyema. And most worrying, perhaps, it is most increased in the most vulnerable population, the over 65s. The reason for this is completely unknown. So there are many theories that we may discuss in the questions, including the use of vaccination in children, but we do not know why this is increasing, but it is certainly on the increase. And perhaps even worse than that, the outcomes in pleural infection are especially poor. So we know that mean hospital stay is up to 2 weeks, surgical rate is 1 in 3, and the 1-year mortality is more than 20%. Now, when I present this data to colleagues in the USA, they tell me that these poor data are because in the UK, we don't have a very good healthcare system. They can do much better. In fact, all of this data, 14 days, 35% surgery, 20% mortality, this is all from studies in the USA within the last 10 years. So regardless of where you are in the world, pleural infection has a very, very high morbidity and a significant mortality, much worse than hospitalized pneumonia without pleural effusion, in which the mortality is only 8%, as opposed to around 20% 1 year. So what's our approach? Well, let's talk about accurate diagnosis first of all. All of you will be familiar with this. This is the BTS guideline on how to diagnose pleural infection. We start in a patient with a pleural effusion. In the context of possible infection, we have to sample the fluid, and it is well recognized now that there are no radiological or biochemical surrogates which allow you to say this is not infected. You have to sample the fluid, and we divide them very simply into 3 separate categories. So we can have the frankly purulent. This is an empyema. This means that it's a macroscopic diagnosis. When you conduct the aspirate, if it looks like pus, this requires intercostal drainage. You could be spoken to by your microbiology lab, GRAB or culture positive. There is no such thing as a pleural commensal. And if so, therefore, if the culture or stain is positive, this is confirmed infection and this requires drainage. And the rest then fit into this middle category, the non-purulent. And these are those in whom we sample the pH. Now, this magic value of less than 7.2 is complicated, more than 7.2 is simple. Where does that come from? I think it's worth just reflecting on that for a little bit. This is the study that it comes from. This is the Hefner meta-analysis published in the Blue Journal nearly 30 years ago. And John Hefner, he used a number of clinical cases to determine which cases were associated with a poor clinical outcome. Now, what does that mean? It means that they needed chest tube drainage, surgery, or they died. So a low pH is a biomarker, a predictive marker of poor clinical outcome. And hence, if the patient has a low pH of less than 7.2, we tend to be more aggressive with our treatment, meaning instead of just antibiotics, we tend to use a chest tube as well. It should be noted, however, that just because the pH is greater than 7.2 does not mean that the patient is guaranteed success. You can see the white here means that it is not a 100% sensitive test. And all of you will know that there is a differential diagnosis for an acidic effusion, of which pleural infection is only one. Now, given that it's such an important parameter for our treatment, we've done some work thinking about when you should question the pH. So when you've done the pH, when should you consider it not to be as accurate, and therefore it shouldn't dictate how you manage the patient? And simply put, sorry, I'm going to have to keep waving. There we are. Simply put, if the patient is suffering and therefore is getting worse despite your treatment, despite a good pleural pH, then this is not a 100% sensitive test, and this patient is going to need a chest tube. So it's not 100% sensitive. The one condition I particularly mention is Proteus causing pleural infection. Proteus is a urea splitting organism and can falsely elevate the pleural pH. So that's one to look out for. Multiloculation I'll come on to in a minute. And then importantly, how accurate is your measurement? And we've done some studies looking at this. So this was perhaps the most boring study ever published. I'm allowed to say that because it's my study. We published this in the Blue Journal about 10 years ago. What we did in this study was we took more than 200 cases of pleural effusion and we subjected them to pH measurement, and we deliberately contaminated them with a number of contaminants. So we either left air in the blood gas syringe, we left lidocaine in there, we left heparin in there, or we delayed analysis. And this column here demonstrates what proportion of pH was made inaccurate by these contaminants. So you can see that air contaminates 71%. Lidocaine is acidic, so it has a big effect. Analysis delayed beyond 1 hour, it becomes unreliable. So this essentially gives you the formula of how to accurately measure pH. You have to exclude all the air from the syringe, use a different needle to the one using your lidocaine, get rid of all the heparin, and analyze it in a blood gas analyzer within 1 hour. Now, what happens if any of these are not true, or you are a bit unreliable about your pH measurement? Well, look how accurate the glucose is on the blood gas analysis. So in the presence of air, even in lidocaine, even with delay, it is very robust. And it is my practice now that if I see a low pH, I will always check that the glucose is in the same direction, simply because the glucose is more robust to measurement. And this is the data on multiloculation. We don't have prospective data on this, just case series data. So this was a 25-year-old man with a right-sided pleural effusion. He was aspirated without image guidance by my colleagues in internal medicine. They revealed a pH of 7.4. They therefore did not drain him. He then came to us a few days later, still very unwell, and we aspirated under direct vision using ultrasound. The pH of this locule here was 7.4. The pH of this locule was 6.4. And this was frank pus. So multiloculation on ultrasound, I think, renders the pH unreliable, and therefore ultrasound is a very valuable tool when assessing these patients, because you know that the pH is likely to be unreliable. So I have some questions which I think we need to answer. Are patients with pleural infection normal? Can anybody get this condition, or is it only people with underlying comorbidities? What is the source of the infection? And then finally, is this term parapneumonic, which we're all very used to, is this an accurate term? So this was a term coined by Richard Light and Stephen Sahn back in the 70s to communicate the idea of a pneumonia associated with an effusion. And I'll come back to why I think we should stop using this particular term. So this is some work done by my colleague Majid Hassan when he was in Oxford with us, published a couple of years ago. He appraised the entire world literature on pleural infection and reported all studies that told us about comorbidity. So this was over 70,000 patients. And the bottom line is that the majority of patients with pleural infection have some form of comorbidity, but only 70%. And that means that somebody who is completely normal, no underlying comorbidities, no immunological abnormality, 1 in 3 of those pleural infection patients you will find to be normal. And that's really very important. So you mustn't be put off the diagnosis because it is a young, fit individual. This can happen to anyone. What do those comorbidities look like? Well, this is the percentage prevalence that we discovered. And essentially, it's what you would expect. Alcohol excess, liver disease, malignancy are all significant risk factors, as is diabetes, as we were all taught in medical school. The slightly surprising one, I think, is probably smoking. So nearly 40% of patients with pleural infection smoke. That hasn't been recognized until we published this particular piece of literature. And my own bias is that the reason that the smokers get more pleural infection, or that it's highly prevalent, is because smoking changes the oral flora and leads to dental caries. Interestingly, the traditional immune suppression conditions, chemotherapy, steroids, HIV, they are the vast minority of risk factors. The majority are diabetes and alcohol excess. Now let's answer that question, where does the infection come from? So this was a schematic that we published in the Lancet Respiratory. Here is the lung. This is a wedge of peripheral consolidation. This here is the visceral pleura, and in blue is the pleural effusion. And so essentially, I'd like to ask the question, how does this occur? How does bacteria infect the lung and then somehow transition into the pleural fluid? And this key event, remember the visceral pleura is supposed to be airtight and watertight. This key event is very, very poorly understood. We really don't understand why some bacteria can somehow penetrate into pleural fluid and result in pleural infection. But we have some data that might give us some clues. So this is some data published by one of my colleagues, Jeremy Franklin. He's a radiologist. We took nearly 100 patients with pleural infection. We did CT scans of them at baseline. And then these were triple scored by independent radiologists against all of these particular radiological outcomes. So they were blind to each other, blind to the clinical outcome, and blind to clinical treatment. It's a very busy slide. I'll just highlight a few things if I may. Increased extrapleural fat thickness, abnormal parietal pleural enhancement, and visceral pleural enhancement are extremely common in pleural infection. And the commonest finding is a parietal pleural problem. So this would appear to be a disease that occupies mainly the parietal pleura and to some extent the visceral pleura. And there must surely be a message there that the thickened visceral pleura or visceral pleural enhancement inflammation somehow leads to transition of bacteria into the pleural space. And once they're in the pleural space, they seem to excite the parietal pleura a great deal. Now, let's come back to this idea of parapneumonic effusion. So in all of our schema, this is again from the Lancet Respiratory, we say that you need a pneumonia adjacent to the lung. We teach our medical students that you have to have consolidation up to the visceral pleura. This results in cytokine release, and this results in fluid. So my question is, how often do we actually see pneumonic consolidation in association with pleural infection? And if we go back to the same radiological data set, this is how often we see it. So pneumonia and consolidation was seen next to the pleural disease in 63% of cases. But that means that in 37% of cases, there was no associated consolidation. And I think that's interesting in and of itself. The obvious explanation, about 1 in 3 of our patients had no consolidation. The obvious explanation is that perhaps they've had more antibiotics or perhaps they've had a longer clinical course. But in fact, statistically, when we looked in this study, there was no difference in length of symptoms or in their use of antibiotics. And I think this is probably due to a separate mechanism of pleural infection. We've now recognized 3 very distinct microbiological radiological patterns, radiological patterns. So this is the classic empyema with consolidation. This is consolidation with cavitation with a pleural infection. And here, the underlying lung appears to be completely normal with empyema sitting within it. And we have some very early data, possibly, that the microbiology of these 3 different radiological patterns is really very different. So with consolidation, we find that it's dominated by Streptococcus, whereas in the absence of consolidation, it tends to be anaerobes and gram-negatives. We need to do more work on this, but maybe in the future, we will be using microradiology, doing the CT scan to dictate what the microbiology may be. And this is a key practice point, I think. Collaboration with your radiologist is required. Most patients with pleural infection in my hands receive certainly an ultrasound and usually a CT as well. So that leads us nicely onto organisms and which organisms are responsible. This is still the largest data set in pleural infection in the world. It's very old now, 15 years old. It's from Nick Maskell from the MIST-1 study, 450 patients, of whom around 300 had a positive isolate. And this is all those 300 positive isolates. I'm putting this up for 2 reasons. The first is to show you that even in community-acquired pleural infection, the microbiology is completely different to what you would expect in pneumonia alone. So you all know pneumonia is dominated by Klebsiella, Streptococcus pneumoniae. Community-acquired pleural infection is dominated by this group, the Strep milleri group, and the milleri bacteria tend to live in the dental flora, in the gingival crevices in the mouth. Strep pneumoniae causes 22%, but look, Staph aureus causes nearly 10%. So it's a completely different microbiological disease to straightforward pneumonia. And if you look at hospital-acquired disease, about 2/3 of these, including MRSA, Enterococci, Enterobacter, 2/3 or so are resistant or gram-negative. And this will dictate the sort of antibiotics that you should use. So let's just discuss that for a second. Within community-acquired disease, we need an anti-staphylococcal penicillin or equivalent. So we would use a third-generation cephalosporin, for example. And you need something that covers anaerobes. So we tend to use a combination of a third-generation cephalosporin and metronidazole in community-acquired disease until we have the sensitivities. In hospital-acquired disease, you need very strong antibiotics, usually anti-MRSA active, and something that can handle resistant gram-negative, so something like tazobactam or piperacillin. That's usually what we would use empirically. There are also some interesting data coming out about the worldwide difference in microbiological yield. So this was a study again by Majid Hassan, looking at nearly 9,000 cases with a positive microbiological yield. And what we discovered is that there's a significant difference in the amount of Klebsiella depending on where you are in the world. So in my part of the world, there's very little Klebsiella, whereas in the tropics and subtropics where you guys are, Klebsiella is a much more dominant pathogen. I don't understand the reasons for that, but I think it might be interesting to speculate on why that might be. Since we're talking about microbiology, it would be nice, wouldn't it, if when we take our pleural fluid aspirate, we always got a bacteria, we always got microbiological confirmation. Unfortunately, that isn't the case. And even in frankly purulent fluid, only about 60% will be microbiology positive. 40%, nearly half, are microbiology negative throughout the treatment course. And hence, it's really important that you have a formula for the empirical treatment you will use. We usually treat these patients for 1 week in hospital and then 4 further weeks with antibiotics. And therefore, your empirical choices are really very critical. How can we improve the microbiological diagnosis? Well, I'm going to present 3 ways that we might be able to. This you can start doing straight away. So this was a study that we did here in Oxford, looking at whether inoculation of pleural fluid into the BACTEC or the blood culture bottle system could increase the microbiological yield. We used a control group, which was patients with heart failure, and there was no false positives in the heart failure group, so it's not an oversensitive test, and it increases your diagnostic yield here in black by about 20%, mainly in the other streptococci group. So this is something that you can do straight away if you let your microbiology labs know. One practice point is that if you send just the BACTEC system, there are some false negatives. So you need to send a plain tube as well as a BACTEC system. This is possibly the future molecular microbiology. On the left here is the 16S ribosome gene that is universally carried by bacteria. And of course, as you will all know, we can do molecular cloning and PCR, similar to when we do, for example, diagnosis of TB where we are. Can we use molecular cloning or nucleic acid amplification techniques, NAAT? Can we use that to increase the yield? Well, it looks like we can. This is some unpublished data. We took 377 samples. 219 were culture negative, 160 were culture positive. So this was a roughly 40-60 split percentage-wise. And when we subjected the culture negative samples to PCR, we got 179 positives, meaning our overall positive yield was about 82-83%. Reassuringly, wherever it was culture positive, essentially there were only 3 false negatives. So this looks like a very powerful technique, but there are some very significant problems with it. So yes, the headline is 82% are culture positive. That sounds great. The problem is it's very expensive. It's not widely available. And if you look at the positives, it's potentially extremely oversensitive. So in some of these patients, we detected 15 different bacteria. And to my mind, it isn't tenable that 15 bacteria are causing a pleural infection. We're now doing some work with quantitative PCR to see if we can tell which is the dominant microbe, and it may be that we can use this in the future. So this is exciting for now, but not for clinical use quite yet. But I think it is important that you collaborate with your microbiologists, and I would encourage you very strongly to do a local audit of causative organisms. Unless you know what's caused your last 100 pleural infections, you won't know what best to use in your population for empirical antibiotics. And we certainly do this every year in my hospital. Now, I'd like to ask my third microbiological question, which is, are we looking in the right place? Here is a histology. You will all recognize this. This is caseating granuloma in a pleural biopsy. And this, of course, is pleural TB. Why am I showing you this? Because if we ask the tubercle, where does the tubercle like to live in the pleural space? The tubercle likes to live in the parietal pleural lining. It does not like to live in the fluid. So the microbiological yield of pleural fluid in TB pleuritis is only 20%. The microbiological yield from a pleural biopsy with growth is something like 60%. So the tubercle certainly prefers the parietal pleural lining. And yet when you and I diagnose pleural infection, we send the fluid, and to date, we haven't really looked at sending the pleural lining. And therefore, we conducted this small study called the audio study. In this, you can see an image-guided pleural biopsy occurring, where we're biopsying the pleural lining before inserting a chest tube into septated fluid. And we submitted the pleural biopsies to the microbiology lab along with the pleural fluid. And this is what we found. So in these patients, only 20 patients, 10% were blood culture positive, only 20% were pleural fluid positive, but the pleural biopsy more than doubled the likelihood of getting a microbiological yield, and it's the typical organisms that you would expect. So this looks like a very exciting possibility for the future. This is not standard practice yet, but may well be, and we're currently planning a larger study to confirm the findings of this small study. This is just a histological confirmation of what I've just said. So here is fibrin, the pleural fluid is over here. This is a pleural biopsy. Here is fibrin. Here are little coalescences of bacteria with a neutrophil exudate next to it. So you can see that they really enjoy hanging out on the parietal pleural lining. And it's interesting to ask why that might be. So for some reason, bacteria prefer to be in the pleural space than being in the pleural fluid. I have a number of theories, none of them are proven, but it might be interesting to consider why a bacteria prefers to grow in the pleural lining. My personal favorite at the minute is that it is biofilm formation rather than any of the others. Okay, let's move on to the next part, risk stratification. Can you and I predict which patients are going to be part of that very high 20% mortality at baseline? And would it be useful? Well, I think it would very much be useful, because if we could stratify high-risk patients, we could then perhaps offer them surgery earlier or offer them more aggressive treatment. If I knew a patient was low risk, perhaps I could offer them outpatient treatment and an aspiration rather than a chest tube and admission. And at least historically, I was taught that septated pleural fluid, purulent pleural fluid, and lots of thickening on a CT scan were predictive of a poor outcome. But in fact, all of the studies that suggested this were retrospective and really deeply biased. So myself and Nick Maskell have done this work, which I'll just talk about for the next few slides. This was some unbiased outcome prediction modeling using the MIST-1 and MIST-2 studies. This was over 600 patients with pleural infection. They had identical recruitment criteria, and we took all of the baseline factors in an unbiased way, and we simply asked the data, what baseline factors predict the outcome, which in this case was death or surgery at 3 months and 12 months. And this is what we came up with from that unbiased, similar to a principal component analysis study. So in brief, this is called the RAPID score. We named it after the 5 components: a lower urea, a lower age, purulent pleural fluid, community-acquired disease, and a higher albumin were associated with a better outcome. That gives you a total score of 7 if you add these up. And then we have a total risk category of either low, 0 to 2, to high, which is 5 to 7. So does it work? Well, this is the data from our original publication. So using the MIST-1 data to derive the score, the mortality in the low-risk group was 2% at 12 months. The mortality in the high-risk group was nearly 60%. So it does appear to be very impressive at differentiating low, medium, and high-risk patients. These were the hazard ratios, very impressive p-values. So is this enough? Well, no, this is not proof. And the reason is that the model is driven by the data itself. So of course it looks impressive, because the way that we were deriving the risk score was by looking at the data itself. We need to validate it against a different data set. And we went on to do that retrospectively with the MIST-2 data set. And here you can see that the low and medium groups have coalesced somewhat, but there is still a significant difference between the two, with a low risk mortality of 2%, a high risk mortality of 50%. So that's better. But the problem with this study is that there were small numbers. You can see that you can clearly see the step down, each one of these step downs represents a death. So there are only about 20 or 30 deaths in the high risk group. And therefore we needed prospective large scale validation of this score. And we have now just achieved that. So my colleague, John Corcoran, published this in the European Respiratory Journal last year. This was called the pilot study, looking at the rapid clinical risk prediction score in patients with pleural infection. So what did we do? We recruited 550 patients from 3 different continents with pleural infection. We managed them identically, and we asked a very simple question: does the baseline rapid score truly predict outcome? And the answer is it does appear to do so very powerfully indeed. So this is the rapid score 0 to rapid score 7. This is mortality at 3 months up the side, and this is a very almost a dose response relationship. So 0 score rapid, nobody died. Rapid score 7, nearly 70% mortality. Let me show you that in a Kaplan-Meier analysis. So here we have low risk, medium and risk, and high risk. These are the 95% confidence intervals, and you can see that we very accurately differentiate between low risk, medium risk, and high risk, with clear daylight between these two and a positive p-value. Does it predict anything else? Well, yes, it does seem to. So I've shown you the 12-month mortality data, but it also predicts length of stay. So if you have a low risk, then you only stay in hospital 11 days. If you're high risk, it's nearly doubled to 18 days. So it does appear to be predicting not just mortality, but complexity of disease. So what do we conclude? The rapid criteria is robust. It looks like it's as good as Curb 65, but for empyema. The tricky bit is, how do we now use it? So we don't quite have that data on how we should use the rapid score to triage patients, and that hopefully is my next study that we're trying to get funded currently. Okay, let's move on to pleural infection treatment then. Here are the treatment options. Of course, it's important to maintain good nutrition, and this is often ignored actually. So we are very pushy with nutrition with our patients. We involve the dietitians. We sometimes NG feed them if we feel that they're catabolic. DVT prophylaxis, of course, essential. Antimicrobials I've spoken about already, and the rest of my talk then will be on so-called source control. So intercostal drainage, intrapleural agents, and then finally surgery. So what's our optimal drainage strategy? What size chest tube should you use? A small bore 14 French tube or a large bore surgical 28 French drain? Well, I was certainly taught that a bigger tube is better, especially for thick purulent fluid, but there are multiple case series showing that small bore tubes are just as good as large bore tubes. There is only one large comparative study in the literature, and that's this study in chest from some years ago. In this study, we took patients from the MIST-1 study, and we looked at their outcome over 12 months, comparing small bore tubes to large bore tubes, and statistically there is no difference. This is therefore the strongest evidence, not randomized, but the strongest evidence we have that the size of the initial chest tube does not make a difference to outcome in your patients. Now, what about patients with purulent fluid? About 300 of these patients have purulent fluid, and in fact, in subgroup analysis, there was no difference again in purulence versus non-purulence, and therefore our go-to chest tube for patients with pleural infection is 12 or 14 French because they are less painful. Now, what about intrapleural treatment? Fibrinolytics have been talked about for a long time in this disease. Why might we think about fibrinolytics? Well, this is why. So here's a thoracic ultrasound. You can see consolidated lung on the left here. Down here is the diaphragm. Here is a large pleural collection with septi within it. And the septi, of course, are made up of fibrin. Here is my chewy needle before I place a chest tube, which I'm deliberately penetrating one and then a second septation in order to end up in the largest septation. And once we've passed the chest tube, we can use agitated saline to demonstrate this. So here is agitated saline being flushed into the fluid, and you can see the bubbles of air do not communicate with the other septations. And this is why septations are a problem, because the fluid becomes walled off and difficult to treat. If we look at this at thoracoscopy, this is what it looks like. So this was a patient with malignant effusion. The lung is down here, the chest wall over here, and the fluid has become infected. You can see these fibrin strands, and it's obvious that a single chest tube is probably not going to drain all the infected material. And hence an interest in intrapleural fibrinolytics for the last 70 years. There are many case series, more than 500 patients in the case series. All of them report success. All of them report clinical success, and there are some reports of bleeding. But we should really concentrate on the direct randomized comparative studies. So these were the first 4 small studies. a total of 104 patients using single agent fibrinolytic. So 2 of them were streptokinase, 2 of them were urokinase, all of them positive. And at the end of all of that, my predecessor, Rob Davis, conducted the MIST-1 study. This was supposed to be the definitive proof that streptokinase worked. 450 patients, hard clinical outcomes, placebo-controlled, double-blind study. And it was the most negative study you have ever seen. So regardless of the outcome, whether the outcome was death or surgery or time in hospital, excluding cancer, any subgroup, purulent, non-purulent, it was negative. Streptokinase did nothing beyond placebo. Now, this was a controversial study because many people believed in streptokinase. One of the reasons I think some people still believe in streptokinase, we now know that injection of fibrinolytic results in the pleural membrane leaking fluid. And we know the mechanism, it's an MCP1 dependent mechanism. So just for context, if I took any one of you without any pleural disease and I injected intrapleural TPA, you would end up with 2 liters of fluid in a chest tube. And I think clinicians think that if they give streptokinase and they come back the next day, if the chest tube is full, they've had a great success. This is simply the mechanism of action of TPA or streptokinase. It does not mean treatment success. So I believe the MIST-1 study was a truly negative study. So we should ask the question, why was it negative? And there's 2 possible explanations. One is viscosity. So let me just explain this slightly. This was an experiment done by Richard Light's group, in which purulent fluid is placed on a membrane and then it is monitored over time. So time here on the x-axis. So after nearly 3, 4, 6, 10 hours, they monitor how much comes through the filter. And you can see that if you incubate the purulent fluid with saline or with streptokinase or with urokinase, no material comes through the filter, meaning that these individual agents have not altered the viscosity of the pus. If you incubate the stuff with varidase, that's a combination of streptokinase and streptococcal DNase, then it all comes through the filter because that combination reduces the viscosity of the fluid. So it may be that it's not enough to disrupt the septations, we also need to reduce the viscosity. And here is the other theory, which is the theory of a biofilm. I think it's very likely that there is a biofilm in the parietal pleural thickening here. And if we look at the microbiology of pleural infection, these are the known biofilm forming organisms. And there are many reasons to believe there is a biofilm by the time you have established pleural infection. So for all of these reasons, we conducted this study, the MIST-2 study that was published about 2011. What did we do? We randomized patients to double placebo, DNase and placebo, TPA plus placebo, or DNase plus placebo. This was double dummy, double placebo. So nobody knew what the patients were getting, neither us nor the patients themselves. And we looked at a radiographic outcome as the primary outcome. So just to explain the radiographic outcome, we used a digital mapping strategy. So in this patient at baseline, their pleural effusion occupies 39% of their right hemithorax. And at day 7, that's reduced to 8%. So their absolute change is 31%. Their relative change was 80%. So it was a very accurate outcome that was a continuous variable. And this is what we found. So this is the main primary outcome measure. I'll just explain the graph. 0 here is the line of no difference. So this patient treated with placebo had no change in their X-ray shadowing over 7 days. This patient treated with placebo had a vast increase in their pleural shadowing, whereas this patient treated with placebo had an almost complete clearance, minus 100%. So what did we find? Well, first of all, we found placebo does work in clearing about 30% of the X-ray shadowing. So placebo means what? Chest tube antibiotics and saline flushes. And if you look, TPA was exactly the same as placebo, exactly the same as the MIST-1 result. DNase on its own, exactly the same as placebo. But if you combine the two, then you get enormously improved drainage up to about 70%. And the majority of patients in the TPA DNase group have complete clearance of their chest X-ray. So it does appear that the combination of TPA and DNase does something biologically to the chest X-ray. But the key question is, so what? If the X-ray gets better, is that good? Well, does it associate with other clinical outcomes, other clinical benefits? And in fact, we think it does. So here are the secondary outcomes from the MIST-2 study, and I'll just highlight the surgical referral and the length of hospital stay. So using TPA DNase, the odds ratio for surgery was 0.17. This means that we reduce surgery by over 80% compared to placebo, and we reduce time in hospital by 14 days. So it was a huge effect, and it does appear to be working on the underlying mechanism, not just the chest X-ray. So what do we conclude? Should it be standard care? Well, even though this is my data, I don't think this should be standard care as yet. I think we don't have enough data to use it in every patient. I think we can use it selectively. So when do I use it? I use it in my patients who are failing medical therapy after 48 hours, and if they have no other treatment option. So if they are very frail and elderly, they have no surgical option, I would go ahead and give them TPA DNAs. If my surgeon says I'll operate on them next week, then I'll give them TPA DNAs while waiting. And of course, we use it as part of a clinical trial as well. Now, the world doesn't quite believe me, and actually a lot of people think it is safe and effective as rescue therapy. So here's a good example. This was Gary Lee's group, 100 patients treated, a retrospective case series, it should be pointed out. All of them were given the MIS2 regime, and they claimed a 92% success rate. My problem with this study is we don't know if it's the drugs or the expertise of the clinicians that results in 92% success, because it's a non-comparative study. But if I did a literature search for this talk last week, and as of last week, there were 450 cases in the world literature of TPA and DNAs, all of them reporting success, and some of them reporting some bleeding complications. Now, I'll just talk to you about this study, which we've just completed and we're about to publish, I hope. So this was a study called Retrolysis, retrospective study of over 1,800 cases of patients treated with TPA and DNAs over 8 years. What did we find? Well, overall, we found a very low bleeding risk, only 2%, so we think this is safe treatment. But we have now identified patients at higher risk of bleeding who are in any of these categories that you can read here. So this, I think, will help us to plan in whom to give the treatment and who to avoid it. There are groups looking at other approaches to this area. So this group, again, Gary Lee's group, are looking at reducing the dose of TPA. And in this case series, they claim that you could reduce the dose of TPA from 10 milligrams to 5 and even down to 2.5 milligrams. I'm not personally very interested in doing that. The bleeding risk is low. I guess if the patient had an extremely high bleeding risk that you couldn't prevent, sorry, I'll just get the lights on. Yeah. If they had a very high bleeding risk, if they're on ECMO or something, then perhaps you might use TPA at a lower dose. In some centers, it is cost saving, and I do appreciate that that can be important. Now, what other options do you have apart from MIS2? Well, this is an important option. So my colleague and friend Nick Maskell published this study in the ERJ, the pleural infection irrigation trial. It's a very small study, and it was a randomized study comparing standard care to large volume irrigation. So this was 250 mils 3 times per day. And what they found was that in the irrigation group, there was a far smaller need for surgery than in the control group. So you can hear in the control group, 50% needed surgery. In the irrigation group, it was only about 15%. Now, this looks very promising. There is a problem with the study, of course, which is that the control group surgical rate was much higher than you would expect. And that was because this wasn't a blinded study. So early data, it may be useful. I would suggest that we need a bigger randomized trial, but certainly it's much less expensive than the MIS2 regime. And if I'm very worried about bleeding risk, then I use irrigation instead. Now, as many of you are pulmonologists, let's talk about thoracoscopy for the treatment of pleural infection. This was a case of mine, infected malignant effusion, and we've used a 2-pore technique here to try to disrupt the septations, unify the space, and then place a chest tube. We can do a lavage as well. Is it worth thinking about medical thoracoscopy for pleural infection? Well, there is some data, but unfortunately it's retrospective only, and it's very old now, from Switzerland, 16 years old. And they said that it was very successful. 91% treatment success in pleural infection sounds extremely impressive with a low surgical rate. The problem is, A, this is a highly selected patient group. And secondly, if you read the publication carefully, of this treatment success, half of them needed further treatment and 5% needed further thoracoscopy. So actually, I don't think it's anything close to 91%. I think it's more like 50% successful, and we need some prospective data to justify this treatment. Okay, finally, let's talk about surgery. This is my last few slides. I think surgery is undoubtedly life-saving in some people. I think it's a very key skill, and our surgeons are extremely skilled, especially locally. We work with fabulous colleagues who are very collegiate and are very skilled surgeons. But I think there are key unanswered questions about surgery. We don't know which patients should be given surgery. We don't know when they should be operated on, and we don't know if everybody should have surgery up front. So let's look at some of the data behind some of those statements. There are many case series showing brilliant outcomes, low mortality, low hospital stay, but all of them are suffer with selection bias, and that's the problem with case series. There are only 2 randomized studies looking at surgery versus medical treatment. The first is the WAIT study. Only 20 patients randomized either to drain and streptokinase or VATS, and they showed a shorter drainage period and a short hospital stay. And then the largest study in the literature is only 70 patients, VATS versus tube drainage. Again, they showed the same as the WAIT study, short hospital stay and lower thoracotomy requirement. But there are big methodological problems with both of these studies. In both of the studies, the medical arm had a very high failure rate. It was a very selected population. There was no blinding and no objective decision-making criteria. So should you use surgery upfront in all patients? I would argue very strongly no. And the reason is, with your physicianly treatment, we know from randomized placebo-controlled trials, 70% are going to get better on their own, and therefore operating on everybody rather, is not rational. I think we operate on people who are failing treatment. Let me conclude just with a comment on the strength of the data. So if we look at the strength of the data in pleural infection in surgical studies and medical studies, we in medicine have 6 studies, they have 2. The total number of patients in the surgical studies is only 90. That's understandable, it's harder to do, but we have over 700 patients in medical studies. The methodology in the medical studies is perhaps understandably much more precise. And for example, unselected front door population is only in the medical studies, not in the surgical studies. Most importantly, I want you to look at this. How many people in the medical arm in both groups failed treatment? It's 40% in the surgical arm and 24% in the medical arm. And the mortality overall is very low in surgical studies and much higher in medical studies. The reason is that we're actually looking at completely different populations. So their average age is only 47, our average age is 60. And this is why the surgical studies, I think, cannot be applied to your standard patient comorbid in their 60s with pleural infection. Okay, so I've summarized that the role for TPA DNAs. I've summarized the role for surgical intervention and VATS. We now have published data that TPA DNAs is cost effective. This is a cost effective analysis in the UK showing that TPA DNAs has a 90% chance of being cost effective. And so we now really need to compare VAT surgery to TPA DNAs. And my colleague Ihab Badawi has just completed this study. This was a feasibility study looking at randomizing patients to VAT standard care or TPA DNAs. And we hope to have some results to you on this in the next 4 months or so. So let me finally conclude, and thank you for your attention. So we need comparative data in pleural infection now. Case series are no good. You need to know your likely microbiology, and that's key to good treatment. The rapid score is reliable and predicts outcome. We don't quite know how to use it best, but I would encourage that you use it. TPA DNAs improves the underlying disease, and I would consider it in patients who are failing therapy. If you don't have access, I would then use saline irrigation. And then the precise timing and the population in whom we use surgery, that needs a great deal of thought. And just as food for thought, especially for perhaps the audience members who are in training, there's a lot of great research that can be done in this area. So here are diagnostic areas that we could look into. Here are early therapy areas. Here are later therapy areas. There's a huge amount of work that needs to be done in pleural infection for us to improve the very poor outcomes. So I will finish by thanking my collaborators. All of this work is not mine. It is work done by my many collaborators around the world, and I should thank all of them. I must thank all of you for your very kind attention. Thank you.
Thank you very much, Professor Rahman, for that excellent and up-to-date lecture on pleural infections. I'm sure it has shed a lot of light and gave us valuable insight as to what has been going on in this field for the last few years or so. So I'm sure Professor Rahman will be happy to take up your questions which our audience has raised today. So before that, I would like to summarize on a few points that Professor Rahman has made during this lecture, which I think we also can incorporate into our practice. Few points which I want to highlight, that we can't always go by these pH values. The magic figure of 7.2 is no longer valid, especially when it comes to multiloculated effusions and the contaminants that are there in the syringes. And another important factor is one point is the how to increase the microbiological diagnostic yield by sending these pleural fluids in blood culture bottles, the backtech the method that you described. I think that also is something that we can take into our practice also when sending pleural fluid for cultures, because most of the time we see negative culture reports. And also the point that you made on sending the pleural biopsy, the image guided biopsy for culture rather than sending a pleural fluid, which can increase the yield by 40%, which was shown by this audio study. I think those are simple things that we also can incorporate into our practice, and simply we can increase the diagnostic yield, because we all know that we all treat these patients empirically, as you said, with antibiotics. So thank you very much for highlighting those points, actually.
No,
And
that's fine.
you,
So, David,
yeah,
I mean, I think just to reply to some of that, I think, you will see a lot more pleural TB than we do.
yes, of
And,
course.
and of course, and I think it's therefore you've got two reasons to do a pleural biopsy, not one. So in my case, if it's pleural infection, we have a less than 5% chance of it being TB. But even I will do a pleural biopsy now because it increases the yield. In your practice, I suspect if somebody is pyrexial with an effusion, it's probably a 50% likelihood of TB. So, and then of course the diagnostic yield is better as well.
And Professor Rahman went on to describe on the risk stratification, the using of the rapid score, which is like the curve 65 in pneumonias, which was something new for me as well. So that I think is something which we can use in our day-to-day practice when we are treating these pleural infections. And then just to summarize on few studies that you were describing, the MIST one, which was an old study, the streptokinase study, which clearly showed that streptokinase has no benefit in the fibrinolysis of the septations rather. So and then the MIST2 study, I think, was with TPA and DNA, which the combination has resulted in good outcome. So that was again, I think, was something new for me as well. So there are some questions now appearing in our chat, in our Q&A box. I would select a few here. There's a question like this, Professor Rahman. The question is, undrained pleural fluid despite attempts of pleural drainage in a patient who is out of sepsis. What are the factors which would guide our decision for surgical referral?
So,
Yeah.
Ranmali, thank you. That's an excellent question. I think this is difficult, but I think we should be very clear. What are you trying to achieve with surgery? And we as physicians need to be really precise about this. The point of treatment of pleural infection is to stop the patient dying of sepsis. That's the purpose. A secondary purpose may be to prevent them having long-term sequelae, such as restrictive lung disease. But number one is number one. And so if a patient has a small amount of pleural fluid, but their inflammatory markers have come down, they haven't got a fever, they feel well, they're eating and drinking, then your treatment has worked. And in fact, what they need is prolonged antibiotics, and they are likely to resorb that pleural fluid. I understand the reason for your question, which is sometimes our surgical colleagues scare us and they say, my gosh, look at all that pleural thickening. If you don't let me operate on them, they will be breathless for the rest of their life, and they will sue you, and so on and so forth. In fact, we do have some data on this. And Richard Light's group published some work looking at the baseline pleural thickening at the end of treatment. And they showed that the baseline pleural thickening at the end of medical treatment predicts the long-term pleural thickening. But guess what? It doesn't affect function, lung function, or exercisability. So this argument that we need to make the X-ray look nice is not a good argument. What I would say is if they're septic and they have ongoing pleural fluid, definitely they need an operation. If they have ongoing low-grade sepsis and they have pleural fluid, they also need an operation. If all you're treating is the X-ray, I would not operate on them. And what I would suggest to you is this: if a patient had a right upper lobe pneumonia, and at the end of your treatment, their inflammatory markers are coming down, and you do an X-ray, and the X-ray shows shadowing, would you do a lobectomy at this point? You would not. You would say, let's wait, and it'll get better. And if you follow them up 3 months later, all of the shadowing has disappeared. And that is the same with the majority of pleural infection. Not all, but the majority. I hope that answers your question.
So, thank you, Professor Rahman. There are a few other questions which are appearing. Right, Dr. Dushant Madhagadar is asking, what is your experience on diagnosing TB empyema?
Yeah, sure. Okay. So I suspect, Dr. Dushant, that your experience is much better than mine, actually, because you would have seen more than me. You as well, Dr. Damith. I've treated quite a lot of pleural TB. It's not a very prevalent disease in the UK, certainly not in the Oxford area. It is much more so in London, where there is a higher ethnic population. I guess I would give these pointers about TB. TB in the pleural space is really two distinct diseases. It is TB pleuritis or TB empyema, and they are very distinct diseases. So TB pleuritis is a porcibacillary disease, very few tubercles, a lot of immunological reaction, and your diagnosis really rests on the immunological reaction of the parietal pleura, which is why we see caseating granulomas, and we very rarely see the tubercle itself. That's and typically you have free-flowing or somewhat septated fluid. That's when you get a glucose level that is low normal and a very high LDH and a very high protein levels of above 60, normally speaking. So that's TB pleuritis. Now, TB empyema is a different condition, and that is the typical cold abscess of TB, where you put a drain in and you receive lots of frank pus. That is usually a mixture of TB plus bacterial infection, and it is a much more deadly disease, much worse to treat. And in those cases, so the difference in treatment is with TB pleuritis, I diagnose them and I drain them to dryness. I don't put a chest tube in and I give them TB treatment. In TB empyema, I put a chest tube in, I give them TB treatment and standard antibiotics to cover gram negatives and anaerobes. And if they're not responding well, I would then operate. I hope that gives some pointers.
Yes, yes, Professor Rahman. Yes, we do see a lot of TB empyemas in this part of the world. Since we are talking about TB, now I'm just a bit curious regarding this TPA DNA study that you did, the MIS2 trial, I think. Am I correct? The MIS2.
Yes, that's right.
Have you done any, subgroup analysis on TB empyemas in this study, whether TPDNAs act on TB empyemas?
So, Damith, I'd love to answer that question. The problem is there were so few TB cases, it's not meaningful. And we excluded TB because TB is obviously a different disease. So I think in MIST1 and MIST2 by accident, there were 2 or 3 cases of TB. So you've asked a very good question. I think there's a good study there to be done. It's never been used in TB pleural infection. And if you guys want to do that study, we should do it in Sri Lanka, not in the UK.
Yeah, of course. Thing is probably TP and DNAs, they come at a very high cost, even in the UK, I think.
Yeah, no, that's right. So it's about $1,500 for a patient, which is enormous. And, hence, I think you could do a study on irrigation, for example. That would be a really useful study to do.
Right, thank you. And Dr. Madhagadri is also asking another question on is there any possibility of mixed infection causing pleural effusions?
Yeah, so Dr. Madhagadara, that's an excellent question. And in fact, we now are understanding that it looks like the majority of infection causing pleural infection is in fact mixed. So historically, we thought 20% were anaerobes, and the majority of those, it was an aerobe and an anaerobe traveling together. We just have some molecular data that's about to be published, I hope, showing that about 70% of pleural infection is in fact polymicrobial. Now, our challenge is to understand which is the bystander bacteria and which is the dominant bacteria, or is it necessary to have both? you will all know that in biofilm diseases, you can have mixed populations that communicate with each other through the biofilm. So I think this is probably a mixed infection in general, but we need more data on the precise microbiology from the pleural space to answer your question correctly.
Thanks, Professor Rahman. Dr. Madhugudri is asking another question on management of chronic infections on pleural, chronic infectious pleural infection.
So I take that to mean a patient in whom there is a cavity, a trapped lung, and you can't inflate the lung with drainage, and they're not a surgical candidate. So these are a very, very difficult to treat group, I agree. The first thing I would say is you need the proper antibiotics, and really, because your route out of this very difficult condition is good antibiotics. So good microbiological yield with a biopsy, that's the first thing I would do. If I would discuss it repeatedly with the surgeons and say, are you sure there's no surgical option? Now, in patients who can't undergo a general anesthetic, for example, they could do rib resection and open thoracostomy. That's very unpleasant for the patient, but that is an option. The medical options that we have are really twofold. One is long-term or rotating antibiotics, and I'll come back to that one. The other is we have started in very selected patients to use indwelling pleural catheters. So we bury a catheter and it allows them to drain their infected fluid regularly at home with long-term antibiotics. I think what I would say, Dr. Madhugudri, is the treatment priority needs to be very clear in our minds. In a patient with a cavity where they've got infection, you will never cure them of their disease. You cannot, unless the surgeon is prepared to go in and do a pleurectomy and insert a muscle flap. You cannot destroy that cavity. And so your treatment intention becomes different. It is to suppress the infection, not to cure it. And so we would then use long-term antibiotics, rotating every 3 months, minimum toxicity to the patient, to allow them to eat and drink and gain weight and so on and so forth. That I guess is my answer.
Right. So as you said, so IPCs, indwelling pleural catheters, has a place in chronic pleural infections as well, because we were mainly using them for malignant pleural effusion.
Yes, so Damit, I don't think they are widely used, and they shouldn't be widely used. These are the patients where you've got no other options. I've treated about 10 patients in the last 15 years in this way, where literally we have no other possible option. So I would use it as a last resort, but it is a good option, probably better than an open thoracostomy.
Right. Thank you. There's another question on treatment of pleural infections. An anonymous attendee is asking, what are your advice on duration of antibiotics in IV or oral in treating?
Yes, so it's a really good question. Thank you for the question. The fact is, we don't know the answer to this question. Nobody has done a good quality study trying to understand the optimal total duration of treatment. One thing I would say for certain is this is a typical biofilm disease. If you stop treatment after 7 days, it will recur, even if you have drained. So I think the minimum treatment duration is 2 weeks. Normally, we treat for between 2 and 6 weeks in total. There is no data on when to use IVs and when to use orals, but I will tell you what I do based on my experience, but not based on data, and I'll be very honest with you about that. I would generally treat them with intravenous antibiotics while the chest tube is in situ in hospital, because they're in hospital anyway, you might as well give them intravenous antibiotics. As soon as the chest tube comes out and I see a reduction in their inflammatory parameters, I would then switch them to oral antibiotics. Once they've been discharged from hospital, I give them a further 7 to 14 days of antibiotics, and then I review them in my clinic. And if in that clinic they are showing a good response at ultrasound and also biochemically, I stop the antibiotics. So I tend to treat for between 2 and 4 weeks, depending on the inflammatory parameters, roughly 3 to 7 days of intravenous antibiotics first.
Yes, I think it's a clinical decision, isn't it, at the end of the day, right? Dr. Asha Samaranayaka is asking a question regarding ADA. Is ADA validated in TB empyema is the question.
So ADA is very much validated in TB pleuritis. TB empyema, I'm afraid I don't know because it's quite a rare entity. But if we talk about it in TB pleuritis, which is the more common entity, then yes, it has a very strong negative predictive value and it depends on the cutoff. It will be particularly useful in your situation where the TB prevalence is high. In low TB prevalence areas, because it's got false positives with things like malignant effusion, it is not so useful. So in fact, in my practice, we don't use it. In London, I know that they do use it, but certainly in Sri Lanka, it would be very useful. But it's most useful as a excluder of TB, not a diagnoser of TB.
Yes, Professor Rahman. We do use this ADA a lot because in lymphocytic exudates, ADA, ADA value of over 50 is quite suggestive of TB pleural effusion.
So, it is suggestive of TB pleural effusion, but it's not diagnostic. And here's an important point. You know, adenocarcinoma will give you a raised ADA and can give you a lymphocytic effusion. So in my practice, where 90% of what I see will be adenocarcinoma, that's why we don't use it.
Right. Professor Rahman, this is regarding the question that I thought of asking you regarding the chest drains. I saw in one of your slides you mentioned that you start with small bore stage 12, 14, like drains, and then if it fails, you straight away get the surgeons involved rather than going into larger bore chest drains. Is that the practice that you do there?
I think so. I would say when I started training, we would always upscale the chest drain. This is 15, 16 years ago. I think we've moved on from there because you have to understand what is the purpose of a larger bore chest drain. A larger bore chest drain will not disrupt the septations any more effectively than a smaller bore chest drain. It's not a magic treatment. If you truly believe it's to do with viscosity and stickiness, then okay, there's an argument, but we've got TPA DNAs to do that now. So right. I do not subject them to ever larger chest drains. And in fact, one of our very old-fashioned surgeons used to say, I won't operate until you put a larger bore chest drain in. And I just said, well, in that case, you put the large bore chest drain in, because I don't think it's rational. I can't see the argument for why bigger is better. We've got solid data that you can treat very effectively, even with an 8 French chest tube. The problem in pleural infection is often not the stickiness of the pus, it is the other things like the septations. So you're right, Damith, if we have a 12, 14 bore chest drain, and they failed treatment and failed TPA DNAs, they go straight to surgery.
Straight to surgery. Thank you very much. And now we are getting sudden surge of questions. Amila Ratnapal is asking, will there be a benefit in higher doses of streptokinase than the trial dose for fibrinolysis? I think this is regarding the MIST-1 trial that you mentioned, the dose of streptokinase.
Yes. So, Amelia, very nice to hear from you. I hope that you're well. We know Amelia very well from his time in Oxford, and we miss having him here. Amelia, thank you for the question. No, I don't think there is a benefit to high dose of streptokinase. I'll say why. You are correct that there has never been a pharmacokinetic study looking at the optimal dose of a fibrinolytic within the pleural space. But streptokinase has particular biological properties that means it's not going to be successful in pleural infection. And one of them is that it is an indirect plasminogen activator. So streptokinase is indirect, TPA and urokinase are direct. Now, what does that mean? It means streptokinase is critically dependent on the amount of resident plasminogen. So if there's a low level of resident plasminogen, even a high dose of streptokinase will not activate it because the low level is the low level. So streptokinase, I think biologically is not a good one to use. And I think we now have 2 randomized studies. This is my view, Amila, 2 randomized placebo-controlled studies that show you that fibrinolytic on its own does not work in pleural infection. I think the previous studies all use surrogate outcomes like drainage, which we now know is a false outcome. So no, I wouldn't be interested in doing a higher dose.
Yes, we also do practice using streptokinase, the intrapleural, some time back. I think, as you said, now it's a negative study, from the MIST-1 study, as you mentioned. Right. There's another interesting question from Dr. Chandimani Udugudagi. In the case of loculated diffusion, if there is inadequate drainage from the chest tube, even after the use of DNases, do you attempt a drain insert attempt insertion of a drain to another locule, or do you then refer to surgery?
Yes, thank you. That's a really good question. Thank you, Dr. Unda.
Very
I
good.
think it depends, is what I would say. The trouble that we run into is we have as physicians to be very clear when we've reached the limit of our treatment. And I think if you have a patient where the locule that you drained has disappeared even after TPA DNAs, and there is one remaining locule, then sure, I would put a chest drain in the one remaining locule. But what about if there's 17 remaining locules? Will you put 17 tubes in? No, I think at this point, we should be clear on the limits of what's achievable for us and when actually our surgeons will do a better job. So one or two remaining locules, yes, I'll by all means. In fact, sometimes I will do an aspirate rather than drainage, so a short-term drainage. But we need to be a little careful. If there's 6 remaining locules, if there's fluid that's septated within the fissure, for example, we just don't have the skills to deal with that, and I think the surgeons should do it.
Yes. There's another question from Dr. Afla Sadikin. He's asking, do you have any treatment difference for hospital-acquired, especially in transdiaphragmatic origin effusions? I think he's asking. Yeah.
Yes. Thank you, Dr. Sadikin. Very nice question. Yes, I think one should be much more aggressive with hospital-acquired disease. So I would have a lower threshold for all interventions. I would certainly use much stronger antibiotics. The transdiaphragmatic origin is interesting, and I think you've raised a very good point, which is in the hospital-acquired disease, I would work much harder to look for the infection source. Whereas community-acquired disease, I'm happy to believe that 70% is due to pneumonia, and we are the pneumonia doctors will treat that. In hospital-acquired disease, especially around surgery, we really have to make sure that the esophageal surgeon or the abdominal surgeon or the gallbladder surgeon has really made sure that there is no ongoing leak. And we need to push that agenda very hard. Because if you and I work hard to cure the pleural infection and the gallbladder is still leaking, then we'll be back there in a week's time, won't we? So that's one thing. I would certainly drain more aggressively. I would use TPA DNAs more aggressively if they're not a surgical candidate. And I would ask our thoracic surgeons to be involved earlier, because the outcomes of hospital-acquired disease are bad and the microbiology is very bad. So more aggression is how I would approach it. And I would do multiple imagings, especially of the abdomen.
Right. Right. Thank you, Dr. Rahman. I think because of the time constraints now, we have to wrap up this session. And so I would like to thank the Ceylon College of Physicians, on behalf of the Ceylon College of Physicians and the Sri Lanka College of Pulmonologists. We are extremely thankful to you, Professor Najib Rahman, for delivering an excellent lecture today on pleural infections. So Professor Rahman has been helping us throughout our academic activities over the last few years or so, and especially you have come here for our sessions also, and we sincerely hope to have you here with us once this pandemic is over and this dust settles. Right. So, and I would like to thank our sponsors as well, the GSK GlaxoSmithKline, for sponsoring and funding this session today. And thank you very much, everyone, for joining in and sending us questions. And I hope most of them, almost all of them, have been answered. So thank you very much, Professor Rahman, again. It was a pleasure to have you. And I think it's time to say good night.
Thank you. And thank you for the honor of inviting me. It's a pleasure to see my friends and colleagues in Sri Lanka.
Pleasure to see you.
Bye-bye now.
Bye-bye.